All right, welcome to my in-service. My name is Brian. I am a student physical therapist from Western, and I'm excited to let you guys know about TBCs, exercise dosage guidelines, as well as the proposed benefits of isometric or eccentric training. So basically, when should we use each? Okay, so we're going to start with TBCs. This is a little table of contents just to let you guys know what's in for the in-service. We have, we're going to start off with what they are, how we can use them, and then we're going to go over one clinical application just to see how you guys like it, okay? Regarding general exercise dosage guidelines, I'm going to be going over ACSM and NSCA guidelines. I want to go over both because both organizations, they sort of focus on different populations, right? ACSM is more towards the general pop, while NSCA is more towards performance athletes. We'll also go over establishing the 1RM. That's something that's really important to do, especially in a setting like ours, where the traditional way of doing 1RM is just not quite viable. And then I'll go over current research on dosage and if it even matters. Lastly, I'm going to go over isometric and eccentrics, again, the proposed benefits, and then I'm going to be going over Keith Barr's research. He's a researcher who has been from Davis, UC Davis, who's been looking at the effects of isometric loading on in vivo ligaments and tendons. So it's just quite interesting, just some food for thought. All right, here we go. So TBCs, what are they? They were developed in 1995 by Dr. Anthony Toledo. I believe he's at the University of Pittsburgh. He's a PT as well himself. And he created it to help clinicians make treatment decisions, quick treatment decisions to help with initial presentation. And this is something that has been updated over the course of a couple of years. And it was most recently updated in 2016. And that's to address management approach and the appropriate rehab approach. So under management approach, we have medical rehab, which is us, and then self-care, which is when we would typically discharge. And then for the appropriate rehab management approach, that's more of giving us an umbrella of where to put them again, whether it's symptom modulation, movement control, which is where exercise comes in, or functional optimization, which is where we start correcting their movements when they have enough strength already. When they have enough strength and have range, that sort of thing. All right. This is a little schematic that the original doesn't quite look like this, but this is something that I've simplified. And TBCs goes by level 1, 1A, and 2. And then these are the actual classifications. Okay? So these are the classifications for pretty much every body part. But for the cervical spine and the lumbar spine, they have their own in addition with those. Okay? So when a patient first comes in, the first thing we ask them is, are they appropriate for physical therapy? Are there any red flags, correct? So we would check their medical screening. I know that we have that in the bag. And then for the yellow flags, that's more the psychosocial, psychobiosocial aspect of it. So are they prepared for physical therapy mentally, emotionally, physically, or spiritually? So that's where you start thinking, okay, is the patient perhaps pain catastrophizing, or are they really apprehensive? And do we need to talk to them first, modify their beliefs before actually grouping them into a classification? Okay? So I'm going to go over the basic groups first, which is these guys. We have pain control, stability, mobilization, exercise, and then correction of movement impairments. So under pain control, that's where, okay, the person is like 9 out of 10. You can't even move them. That's where you place them in, okay? For stability, that's more for an external support. So you think about like braces or taping, more like think about like an ankle sprain. You would start bracing that immediately. For mobilization, that's what I found to refer to manual therapy. So any soft tissue, any joint mobilization, manipulation, and then exercise is the big, exercise. And then correction of movement impairments is when the patient is almost prepared for discharge, but the way they move is just not efficient, according to us. Okay. Down here is the symptom modulation, movement control, and functional optimization. Those were the three subgroups that I mentioned earlier. Sorry. Do you guys have any questions yet with this model?
Just real quick, what does TBC stand for exactly?
Treatment-based classification. Yeah. Did I not mention? My bad. I didn't mention that. Are you guys getting it so far or not so much? Yeah. So this is what goes on in my head when I think about placing them into certain classifications, placing patients in certain classifications. Okay. We can go over the central the cervical spine and lumbar spine. So for lumbar spine, there's also traction, and then for cervical spine, there's centralization, headache reduction, and then conditioning or exercise tolerance. So under conditioning and exercise tolerance, you can put patients who are perhaps like dizzy, like people with their vertigo. Okay. So why should we use them? So I think we should use them because it really simplified my clinical decision making. It helped me a lot when I was just putting them into certain subgroups. It simplifies documentation. So I'll go over how to document it, and it's really simple. And it allows follow-up clinicians to quickly read just a single sentence and really understand, okay, a patient is in this subgroup, I'm going to do these certain exercises, even without looking at the rest of the documentation. So it helps out with efficiencies and productivity within the clinic. It also helps a lot with patient buy-in. In a study by Warren, they were measuring the global perceived effect, and it showed that there was an overall effectiveness of treatment. So patients actually felt that, okay, this treatment was more organized, and they just felt there was a better effort from us.
All right. As far as like when you with the categories that they fall into, what if they don't fall into any of them, or what if they fall into all 3 or 4 of them at the same time?
Yeah, that's a good question. They can be combined. So you don't have to isolate them to a single category. You can combine them as much as you want, which is also the cool thing about it. It's quite adaptable in that sense. Does that answer your question?
So I mean, it sounds like when you had that slide earlier, where they had the little classifications, it almost seems like it would be more like a pie chart where like maybe it's more 60% pain, and then maybe 20% stability, and then maybe the exercise another 20%. So that part would shift.
Yeah, that part would shift, and you would just order it just in priority. So we can go over a clinical application. All right. So we have a 55-year-old male complaining of back pain after playing pickleball about 2 months ago. Pain is rated at 8, but with movement, and a 2 when in static positions. He describes the pain as an ache that becomes sharp with end-range movements that does not travel, and denies any numbness and tingling. And these are some of the objective measures. Can you guys see that? We have right side bending, only 10 degrees or to mid-thigh. Left side bending all the way to the lateral joint line of the knee. Lumbar extension, it goes all the way to mid-thigh. Right quadrant is positive. And then unilateral PAs from L2, 3, 3, 4 is positive. And then bilateral SLR is negative. He only subjectively reports tightness, okay, hamstring tightness. So what do you guys think? What's the most likely diagnosis?
Or which classification to put them into?
No, just the diagnosis. Just what you guys think it is, not the classification yet. So I got this, and this. Just off the top of your head, what do you guys think?
A.
Yeah.
Yeah? Good. Insane. Nice. And then what TBC would you guys give? So someone who presents with lumbar facet,
Mobilization, manual therapy.
mobilization, manual therapy, okay. And then what else would you guys put afterwards?
Stability.
If you were to give a second one.
Stability.
So the stability is actually tricky. So would you put a brace on them? That's what they mean by the stability.
No.
Yeah.
Not
Pain.
Yeah. That's the only tricky one.
Oh, okay.
Pain
Pain control?
was 8. Was movement.
Yep. 8. So pain control is always in the picture.
That could be with like movement modifications or symptom modifications.
Yeah.
That could reduce that or manage that too. So with exercise.
So pain or we got mobilization. That's number one for sure, right? This is what I had: mobilization and then exercise in the domain of strength. So under exercise, that's where you can put, okay, you want to exercise for stability, you want to exercise for mobility, whatever you'd like, however you'd like. But you try and make it into, one or two words where it's like, okay, I want to focus on strength, or I want to focus on dynamic balance, something like that, okay? So that's literally what the TBC would look like. It would look like mobilization followed by exercise. Is that something you guys would agree on?
So mobilization would be gapping or something else, on one-sided mostly?
Yeah, that's something you would do on day one, right? You see the patient with lumbar facet, immediately you'd want to mobilize their lower back a little bit manually. Okay? So if I were to ask any of you guys, if you just read mobilization and then exercise for mobility or strength, we would all have pretty much the same answer, right? It would be mobilize the back and then whip up some home exercise program that addresses their instability or whatever compensation they present with, right? That way you don't have to, necessarily read the entire documentation. You can just read that part and understand, okay, that's where I'm at. Okay, that leads me to exercise dosage guidelines. So there's a huge table of ACSM's guidelines. For hypertrophy and strength, we have 8 to 12 reps with the same sets and amount of rest, but the difference would be the percentage in 1 RM, okay? And I'd also like to note that for ACSM, for strength, there's a beginner and advanced. And for advanced, to be in their classification advanced is to be able to squat your own body weight. So I don't think it's viable just yet for a rehab standpoint, but it's still good to know. Okay? And then for power, we'd be looking at 3 to 6 reps with 3 sets and 2 to 3 minutes of rest. And then for endurance, it's anything under 70% 1 RM, up to 25 reps, and a lot of sets with less than a minute of rest, which sounds about right. For NSCA, it's slightly different. It looks a little more complicated, but that's because they want to address the athlete. Okay, they're not so worried on performing a lot of repetitions. They want to worry on quality. So for strength, we have 67 to 85% of 1RM, whatever that means. And then reps, 6. Sets, 2 to 6. And then for rest, it's 2 to 5 minutes. For hypertrophy, over or equal to 85% 1RM, which I think is a lot. 6 to 12 reps, 2 to 6 sets, and 30 to 90 seconds of rest. For endurance, anything under 67%, over 12 reps, similar amount of sets and rest. And for power, they start with 75 to 85%, 1 to 5 reps, and then a longer period of set and rest. But for them to improve in power, they want to go to 80 to 90%. So that's the progression they're trying to make. Okay. This is just a big table of all of them comparing side by side, just for your own reference, if you guys ever want to look back at it. But first, like I was mentioning earlier, we need to establish 1RM, right? So.
Sorry, bro.
Sorry, bro.
Yeah, this guy is crazy. So establishing 1RM, this is a study by Buckley and Borg. So the Borg scale, you guys know. This was done in 2010 actually, and they had basically 3 groups. Experiment 1, Experiment 2, and 3. And they had 2 focuses. One focus was more towards strength and the performance side, and one focus was more towards the rehab side, which is where we are. So that side was actually for Experiment 3, where they would perform 15 repetitions to reach a 5 or 6 on their modified Borg scale. You'll see the modified Borg scale on the next slide. Okay. And they chose 15 repetitions because they want to focus on the applied relevance of fatigue. So in rehab, we're worried about frequency, correct? We want to make sure the patients are able to do it over and over again for as long as they live. And that's why they chose 15 repetitions, okay? So finding 1RM for using this scale, what you would do is you would ask the patient to perform 12 to 15 repetitions, and then simply ask them after 2 repetitions or so if they are around the middle of this Borg scale, which is strong, heavy, or right above moderate. Okay? Just like that, from the article, you're able to find the 1RM just for a rehab setting. Okay? So it's much safer than what the guy earlier was doing, and it's also quicker because you're going to do that amount of repetitions anyways, and you're going to ask those questions anyways. Okay, so now that we know how to get 1RM, do repetitions even matter at all? There's a study by Schoenfeld et al., and they challenged the whole repetition continuum. Those tables, they challenged all of it. And this was a literature review with a sample size of 545 over 22 studies. And of those 22 studies, I found it interesting that only 5 had trained individuals. So that does have some, specificity for us as rehab professionals. And then it was mostly untrained. And what they found was that for strength, heavier loads were still favored. However, statistically, there were minimal differences across loading zones. So you don't even really have to follow that 1RM protocol. You just have to make sure that the patient is truly trying based off the Borg scale. Okay? For hypertrophy, similarly they found whole muscle growth achieved across a wide spectrum as long as it was greater than 30% 1RM. So again, you don't have to go to, what were those numbers, like 70% and above for hypertrophy. They found that as low as 30% and above, you could get similar findings independent of age or training status, which I think is great. And then for endurance, it's just the same. Endurance never changed. They found that was 15 plus repetitions, as long as it's under 60% 1RM, then you're good to go for endurance. So this was their repetition continuum that they were challenging, and then this was just like this information was just an overview of this. This is what they proposed. These little small excerpts, that's basically what they're saying. Any questions so far, guys? Pretty straightforward, or am I being confusing? All right, last part, eccentric or isometric. So the benefits, proposed benefits, and possible limitations of each type of exercise. So I grouped these 3 studies, and the benefits of an eccentric, that's where we're going to start, is that it can help normalize tendon structure, and it mimics sport movements most closely. It reduces thickness of tendons. Usually when tendons are pathological, they get thicker and thicker, like the Achilles tendon. And then they also have an hypoalgesic effect, and this was found basically in 2 of the 3 studies that I found. And then one study that I looked at that addressed sarcopenic adults, sarcopenic older adults, found that even minimal dose eccentrics were good enough to retain the same muscle adaptations when compared to younger adults. So by minimal dose, I do mean what I meant, the lower ranges of the earlier dosage guidelines. What are some potential limitations? So eccentric exercises are typically painful and require movement. So what happens to the kinesiophobic patient who is stressed or who is heavily guarded, has muscle spasms, don't want to move at all? And oftentimes they might not meet the load requirements for a certain individual's functional demands, secondary to pain. They can try to get into it, but once it starts hurting, the patient might just say, no, that's too much, I quit, right? So that's where we head over to the benefits for isometric exercises, and it seems to work really well as an adjunct to reduce pain while also increasing function. So in this study, they assessed effects of, they assessed 11 individuals with rotator cuff tendinopathy, and coupled with just traditional strengthening, they found better improvements in pain, function, strength, and EMG activity in just 6 weeks. So it's pretty quick. In another study, this had a sample size of 52, it was a comparative study, and they were comparing isometric training with ultrasound versus aerobic training with ultrasound with people who have osteoarthritis in the knee. And I actually found that pretty interesting because, OA, you want more and more and more movement, correct? But what this study was proposing was that actually isometric training did better than aerobic training. Now we're going to get into some of the proposed benefits. This is a little bit experimental, and this is Keith Barr's whole thing. This is his life basically. And this study followed a NBA player who had, over the course of a year and a half, who had a central cord patellar tendinopathy. So that is literally a hole inside his patellar tendon. So what they did was they combined a nutrition aspect to it. It was gelatin, along with really heavy isometric loading to provide significant stress relaxation to that tissue, to that injured tissue. And they found that after a year and a half, with the MRIs, there was a decreased pain and improved performance, along with a full regeneration of that central core, which is quite astonishing, I think, because he's an NBA player. I'm sure he's done previous treatments to it. It seems like this one works. Before we go further, I do want to go over stress shielding and stress relaxation. Are you guys familiar with those terms? Not too much?
No.
So for stress shielding, that's essentially when a stronger tissue shields the weaker or injured or potentially pathological region. So if we take the patellar tendon, essentially with the central core, the outer regions of it would be shielding the inner regions. And the amount of load would never reach the center had he not done the isometric exercises. Does that make sense? So this is also where I talk about immobilization. If you immobilize something, that's also considered stress shielding, correct? Because now that brace is that stronger structure. And so even immobilizing for 10 days has shown to reduce tendon collagen synthesis by up to 50%. So putting that brace on, really not that good. It continues to decline in collagen synthesis over 23 days. So this is a domino effect. The more you put on a brace, it's just going to get worse and worse and worse.
No, I was kind of curious because if you're loading the tendon, then there's a recovery time frame that is also required in there. Could that brace still be used in conjunction with the strengthening for the recovery days after you did like a heavy isometric activity with them?
That's a good question, and I don't know the answer to it.
Because I mean, unlike NBA players, people might have to pick up the kids. They might have to go to the grocery and still get stuff at Costco during those times, and they struggle sometimes with being able to find the recovery days.
Yeah, that's true. Yeah. One thing is that this was a longitudinal study over a year and a half, so the protocol that they went over, it wasn't too strenuous, I think. And we'll go over that soon. And then for stress relaxation, that is when the tissues surrounding finally relax, and then the center gets the appropriate mechanical stimulus needed for growth. So these are the findings. He used 3 isometric exercises: the leg press, leg extension, and the Spanish squat, all held in mid-range. And they started at 10 seconds, and then they ramped up to 30 seconds after 6 months. I think they were doing it by 5 seconds every time they had treatment sessions. So we'll take a look at this guy. That's his hole in the beginning. And then at the end, it was barely there. And in fact, it wasn't there at all, which I think is crazy. So yeah, that's really all they did. They did isometrics. He's an NBA player, so load in terms of eccentrics and concentrics was super high. But for isometric, all he needed to do was 30 seconds of isometrics, 3 types of exercises. Although over the course of a year and a half, there's no way we can monitor that, but if a patient can do it,
Was it just a single case study so far that they've been able to find that out? Because I'm thinking the general public wouldn't have the genetics of what maybe a professional basketball player might have.
Yeah, that's one of the
Either.
big limitations of the study because it's so new. Yeah, so this is the tendon ligament protocol that Keith Barr used, as well as what he used in the other study as well. And it was just 6 to 10 minutes total of isometrics, followed by 6 hours of rest. So you go home, rest, do your thing, and just 6 to 10 minutes was enough to increase phosphorylation of the key kinases for protein synthesis in that area. And it actually, effects were seen after 6 to 10 minutes, and you could see them for as long as an hour afterwards. So that's how quickly our bodies are able to adapt. Okay? So my take-home messages are using TBCs can expedite the clinical decision-making and improve communication through clinical settings, right? You get one sentence like that and you'll know immediately what to do for the most part. For exercise dosing, now we know that it's highly variable. It doesn't have to exist in that repetition continuum, and as long as it is specific to the patient and based off of the patient's level of training, we're pretty much good to go. In terms of eccentric and isometric, both have great benefits. However, isometric loading may now lead to more of a regeneration of the tissue, while eccentric loading still continues to excel in just performance. And that's just based off of the studies that I've read. And these are my citations. Thank you for coming.